proceed.
Yes, thank you so much, Chair. Our ICU is operational, and we have 7 beds, which are most of the time full. And the NICU, we have 60 beds. That's a neonatal unit. We have 60 beds. And we have like 80% bed occupancy of the NICU. Now, as regards what are the specialized things which so unique about us is that we're managing now babies who are born at a weight of 500 grams. That's half a kilo. And we have statistics age going to school who was born at 25 weeks and is alive. And is a testimony to that. And we continue because of the increased services and specialization. That unit is fully packed. It's fully packed, and sometimes is actually fully congested. Now, we have other new services within the hospital, and this actually include the IVF. There are couples who have failed to conceive, especially after 1 year. This started operational in August 2024, and we're proud to mention that we've had 11 successful pregnancies coming out of the service, and 2 is that we have had 4 babies delivered because we stagger them in the course of offering them the service. The challenge: IVF is costly and requires more expensive resources, and whatever budget we have is so limited that we cannot provide according to the demand which is there. And 2 is that even if, because this is a service which is paid for, when our clients pay for it, that money goes as NTR, and we're not what the budget. So you have food in your plate, but you have more people who want to eat it, and they have the money to use it. It's a big challenge for us in relation to actually those supplies regarding those specialized medications. We have started pinhole surgery as a hospital, and our dialysis machine is running currently to support, and we don't have any referrals going to Kirudu. And we have a physiotherapy unit which is actually running, and now we're encouraging pregnant women to do exercises so that we can reduce high blood pressure. You can reduce, you can actually encourage women to deliver normally, but also to heal immediately after childbirth. The hospital has the best CT scan in Uganda. I think is the second best to Medipal, where you are able to do so many investigations, including those. We have a tissue pathology, and we also have things to do with if you have challenges with passing urine, then we can basically help you, especially all through. Now, as regards what Chair you mentioned about charging the facility, the government over a period of time, and the year under query we had 9.8 billion, and in the brief which I shared, there is a target of increase collected. From the beginning of this financial year, we also see a trend that the money which is collected is increasing because the patients are actually coming for the service. And the month of February, which is only 28 days, I think we hit our target of 1 billion 59 million in that month. Maybe if you had 2 additional days, could have gone maybe another 200 million on top there, which is something bring back to the National Treasury as what? As an entity. Now, in relation to that, how much do we charge for ICU? We charge 1 million per week. 1 million per week is the lowest. And for patients who sometimes cannot even afford, we do actually actually waive it out. We don't deny them the service because they have not deposited. For us, we first treat, and then you start asking the money later. The hospital has embraced electronic medical records in all service points, and this has helped us improve on accuracy and access to the patient records, and also reduces the delay of patients. When they come in, we're able to log in your name, and then we get all your details at once. But also it has helped accountability. I will know that my doctor so-and-so has seen this number of patients and he started working at this time. In the medical records that can easily be traced. Chair, you mentioned about the role of the hospital, the mandate. We do training. In gynecology and obstetrics, we have residents of anesthesia who also interns in different disciplines. That's pharmacy, nursing, and then we have fellows, which is really an advantage as an institution that we are of the government. But being a super specialized, some of our human resource, we have to send them out so that they can actually acquire the skill, and that most times has cost us to spend a lot. If you have to send somebody in the UK for 2 years, it takes all the budget for that training. As regards governance, we have quarterly board meetings which have been happening, senior management meetings, core management on a weekly basis for us to track on some of the activities happening in the institution, and quality improvement meetings within the hospital. And every morning we sit like this to review the last 24 hours, to look at the critical cases we have managed, to see monthly, basically to review some of the activities. As part of community engagement, we have been involved in prematurity, which is really very important. We're in the National Medical Stores medical camp recently, engaged in the various talk shows within the country on some of the related topics. The drugs these women take during pregnancy, some of them are harmful, how to seek care, and what services we offer as basically a facility. Now, do we have challenges? Yes, many. One critical one is understaffing. We're supposed to have 971 staffs in the facility, but currently we're standing at 43.6%, which is very low. And having critically sick patients requires more patients, but also requires more hands to be available at any one time. So I just gave an example of the neonatal unit. Neonatal unit, where you have different categories of patients. The critically sick requires like 1-to-1, but as we of now, we are like 1-to-6. 1 nurse to 6 babies, which is unbearable. The staffs are getting burnout, and you can easily make mistakes when you're providing basically the services. So that's a big area we are saying that we need to increase on the human resource number, but also the some specific specialties. Preterm 45. They are less than 32 weeks. We don't have a specialist doctor basically to check this. Specific day, we carry them up to Mengo, they are checked. We carry them up to Zambia, they are checked and brought back. That means that staff has gone with 2 or 3 babies to check. Because the danger of that baby will survive, but later come back, the eyes, they cannot see. So we need somebody specialized in terms of looking and rectifying these babies when it is still early. When you go beyond a certain period, you end up with a blind child. You have made the baby survive, but the child is blind, which is a disability. Pediatric surgeon, you asked about our relationship with the main Mulago. Currently, we don't have a surgeon. So any baby which requires surgery, baby tool, main Mulago Hospital, and that requires a bit of coordination. But if you had our own doctor within on the hill or within the hospital, then that movement to creating infection, but also there are dangers of you baby getting cold and the next day that you have actually lost that baby. Some babies are born with condition. That is what we have been currently doing. Now, it is somebody we don't have, but using the collaboration within the hill, it is what we actually do. The other is the training budget. Key challenge we have currently is that training. Like currently we have one of our specialists in the College of London. He has taken the whole budget for the full year because you want specialists in that area. You end up using the whole budget in one person. So we require kindly support in that area if we were to offer basically these services. Now, the structure of Mulago Specialized Women Neonatal Hospital is a beautiful hospital, but over a period of time we have noted that there were some infrastructure defects in the roofing. When rain comes, as an ED of the facilities, you're just worried which place is going to leak now. There was designer challenges where the roofing, the nails were put in the valley, and with the aging process, when there is any leakage, there is actually water pouring into the facility, and that has caused challenges. First of all, an embarrassment to us. Two is that it is dangerous for the staff. When the floor leaks and you walk, you can easily slide and injure yourself, leave alone the electrical challenges and also the walls basically peeling off. So we made a report about this, contacted the Health Infrastructure Division of Ministry of Health. They have assessed and they have actually recommended that the roof needs to be replaced completely at 1.3 billion. It is a big challenge. You pray for rain, but when the rain comes, you worry that this NICU is going to leak or the main presidential suite is going to leak, which is a very big challenge. Our other challenge here is the equipment, the maintenance of equipment. The hospital is supported a lot with equipment, and CT scan, the oxygen plant, including the NICU, all those equipment require maintenance. Now, the estimate is about 4.4 billion for the maintenance of equipment, but we only receive 1.3 billion and a shortfall of 3.1 billion. This creates a very big problem in that as the equipment malfunction, we are not provide the service, and if we are not able to provide the service, we are not able to generate the NTR. We were usually given a target that generates this level of NTR. Now with the malfunction equipment, you are not able to basically generate the people who look for a service outside, and that is actually unfortunate. And that is similar to even the inadequate budget for medicines. When you don't have any medicine or supplies within the facility. I give an example. For you to investigate an infertile couple, you run like about 6 or 7 tests. And if one of the tests is not available in the facility and say you go and run this out, our clients will tell you, why do you prick me? And then I go and be pricked again outside. So he goes with all the services and he gets us there, and at the end of the day we fail to offer the service but also to receive the revenue along those lines. So the specialized medication, the specialized supplies for some of this IVF is really in their need for us to offer the service, but also to generate the NTR. Similarly, the supplies from national medical stores have never increased since 2019. We're giving us 2.5 billion. Our patients are increasing. It is the same. 2, the patients have been asking us to start seeing their children, and that demand has gone to our parent ministry, and the ministry has actually requested us that you need to start seeing these children you are delivering. We have delivered so many babies in that facility. They want to come back and receive the services. The budget for national medical schools is actually low. 2.5 billion.
What would be the appropriate?
If they can give us 5.4 billion, that could help us offer the services we have. High utility bills for electricity and water is a big issue, and the bill for the allocation for water is 2.56 billion. But you find that our bill is 1.38, because on average every month it is 115 million, around there. That's what we spend in water. So we're all the time going into areas, which is very unfortunate. Similarly, the electricity, our gap is 0.3. The machines we have require water and power. They have the machines in NICU, and then also the ICU have to run all the time. All that requires electricity, and laundry requires water. Staff requires electricity. That's why the bill is actually high. Chair, as a plan, we, for the vote, we want to strengthen our services as a facility. In terms of the infrastructure, if we are supported to work on the roof, that would be good. How can we have more human resource as a hospital? If you can just reach 60%, that would be really good for us as a facility. And also to improve on governance and all the other investigation. And we have listed some things which are just immediate, which we can think of working on. One is the demand for the introduction of pediatric services. We feel there is space within the facility which we can use for these pediatric services, starting slowly but offering super specialized services. And the utilization of the levels of theaters we have, which are started. We have high level theater which is in level 7, which is operational now. And the maintenance and the repair of the critical equipment, which is really key. We're also trying so much to strengthen the billing process that all the patients who receive care there should be able to pay for the service, because it is really affordable. And reducing the stockhouse and then addressing this, the staffing gaps. The other is protecting our equipment. While the main Mulago Regional Referral Hospital has a dedicated line, for us, when power goes off, it is just, we get switched off also. And you have to switch on the generator, which is also not easy. If it's the whole day, then the fuel consumption goes high. So we're working out with the UEDCL to ensure that we could have power stabilized by having a dedicated line. And 2 is, the other one is just to improve on our turnaround time. When you come there, then we can be able to offer a service within a short time. If we are provided with the resources, that would be good, and then especially with the human resource and all what we need. The training is key, and then tracking all in the facility. In medium term, we want to expand our IVF to have couples donate gametes, donate over, for those who are not able to, because any eggs, but there's a possibility that I can bring a sister who can donate, then it is stored there and I can receive it. That is really will be very key. But also we menopause is also something. We are growing old. At age beyond 55 years of age, some challenges coming. That clinic is starting, but we need to, they can join in with the fellow women and use advanced. The other which we think we really very important is the interventional radiology, where we don't need really, if you have a problem or cancer, we did not to cut you open. Can we use the new technology to access where the cancer is and then inject the medicine there and then you follow up? And there is already one person who is in training in Arusha. We just need to ensure that when that person comes, he has the equipment basically to use to support that. So Chair, go back, maybe if there is any question I've not answered. About the baby, we also saw that clip. It is not true. It is from Mulago Specialized Women Neonatal Hospital. The color of that building does not resemble Mulago Special Women Neonatal Hospital. We have tried to trace it, and that color is from Zambia. It is not even a Ugandan baby. It is circulated many years back and came recently, little after the elections, and people were able to trace it that picture was from Zambia, not from actually Uganda. The kind of patients we receive sometimes are referred from Mulago, from Kawempe and other lower facilities. And these patients really need either ICU services or they need the neonatal care services. Two is that most of those patients also cannot do what? Cannot afford the low prices which you offer there. Those are some of the cases which are contributing to the waivers which are high. And as I speak now, the last financial year, we had 1.7 billion waived because of those referrals from the lower facilities, and which is actually a big area. Mental health, we have a clinical psychologist, and in the new recruitment plan, I think we're planning to recruit one more person to support. Even childbirth alone is traumatic. After delivery, more traumatic, depression usually comes in. The one person who is there is currently overwhelmed, and with the little budget, we're planning basically to recruit one more. But if supported, we can even offer more. The other question, which is I think that is all, Chair. If there is anything,
Susan, that has been responded to. That video was not from Uganda. They have tried to trace it. And I think Ugandan out there can know, but you'll give just in a minute for whoever is listening to us or viewing us for to know if I'm going to Mulago Women Specialized and Neonatal Hospital, who should go there? In brief, for somebody, for someone who wants to understand, who should go to Mulago?
Thank you so much, Chair. Now, Mulago is specialized for women reproductive services and newborn. Anyone who is planning to conceive, for example, can use the facility. Anyone who has a pregnancy and has challenges of carrying that pregnancy up to term should actually utilize the facility. Anyone who has had a challenge during childbirth, has lost any baby, should be able to utilize that facility. Anyone who has had challenges of conceiving, okay, You have now facilities which we have specialists and facilities which can assist the person of that kind. Now, there are those who are seeking to know about their health, well-being, related with women, screening for cancer. We have the services there. But even those who have been detected with cancer can go and seek services within the facility. And if you have any challenges, you have sweating, challenges with the menopause, you can also receive services from that facility. For the men, we are also screening them for prostate cancer. We do a random test so that we're able to offer you and link you basically to care. Thank you.
I don't know when we should go to Mulago. Some people think it's only for women. And now the other area of neonates, there are many of those then transferred, because you know this area country. What is the rate? Is it increasing? I have my second born was a neonate at 1 kg. But you know what it means to bring out such a child. And for now he's in P4. So when somebody speaks about neonates, for some of us who have gone through it, we know what it means. And these 1 to 6 nurses, really, this is too much. If there is a sector that should be, I mean, where funds should be allocated in terms of 100%, when it comes to all the care, you don't know what it means to lose it. People come having taken so many years to get pregnant. Somebody gets like a baby, whether 500 grams, very tiny as it is. So it is a sector, honorable colleagues, that we should take interest in. The neonates is a very unique sector, and if I want to know from you how much money has been allocated to Mulago. We intend to recruit, but honorable colleagues, we should push for 100. Are very important. The neonatal is a bit, it's unique in nature. That sector should be taken care of. You spoke about the waiver. For me, there is something I don't agree with. Yes, you can waive for those who we think cannot afford, but you know medical care is expensive. Whoever takes a step to come to Mulago Specialized, most of them were here with Chirudu, and they were like 80% of Ugandans cannot afford some of these services. How do we look forward to unanimously serve Ugandans when it comes to your services? You know, those things of waiving, it's at the discretion of your team to waive. We know there are those who can afford, but how can we standardize? Because, you know, other things, you may not get the statistics the way you may want it. How can we ensure that we get services to as a low cost as we can? Because waiving is okay, but it's discretional. It is discretional, and I don't know whether immediately misused by whoever is given the authority to. Then we talked about the water bills. The water bills are a challenge in most of the hospitals. What plans do you have for in line of water harvesting? All those other, because water bills, and at times the wastage by the patients themselves. How do we regulate the use of water? Because as long as we don't have mechanisms to reduce on the waste, these bills will increase. The other thing we cannot afford to live as a country is power shortages in Mulago. In these hospitals, we should have 100% supply of power. We have excesses. You pay for deemed energy. For all these state houses, no power has never gone off in a state house. So if you can, in the president's residence, power should not. And yes, you can run a generator, but that cost comes back to me as a patient, because that is part of the operational costs of Mulago. We produce power, we sell it outside. These colleagues, we should have it a must for all the hospitals to have electricity full time. Goes off, on and off. In a country that generates its own power, when you even pay for dimmed energy, you consume what you produce, what you can't. Do you know how many people have died because of that? Power off. In the neonatal, but I saw what happens there when how do you call it, those incubators, when an incubator goes off, the time at times for you might be lucky that it's somehow automatic, but in Masaka Regional Referral Hospital it goes off for 5 minutes. I'm telling you, scuffle, we lose lives, people die. So we can afford anything, but switching off power, I mean power, those power shortages and breakdown in hospitals, we have the capacity to minimize that. And I think one of the resolutions we should make is this: if State House can have supply of electricity throughout, then we cannot see hospitals. So, yes, Honorable colleagues, if there is anything, yes, Honorable Bangura.
Thank you very much, Madam Chair. State House, State House. No, we need power everywhere, but don't make reference to State House. It is not the only privileged one. We want to make sure that the health centers and facilities are privileged. Madam Chair and colleagues, and for the benefit of our guests this morning, my name is Frederick Angura, and I happened to have delayed to come, Madam Chair. As I told you, I was on my way. And where was I? I was actually at the Specialized Women Hospital. I want to thank this team that now my people from my constituency have embraced the good services of the Specialized Hospital. They are there, and I've been visiting one again. The only problem is, of course, when it comes to the good service that you offer, as Doctor has said, that you first offer the service, then you now discuss about the bills. So people are happy. When the service has been given, they start now looking up in the ceiling and calling us. And that was one of the calls I responded to go and see. And then when I get back, you'll know what to do. But I want to appreciate the good work that is already kept asking here, and we thought one day you would be able to consider. This is the Mulago Women Specialized Hospital, but you're also talking a lot about men. Out there, men are still complaining. Why don't they add this name, stroke men? Because they're specialized services. Now you're attending towards all of us, but just that word, women only, it is continuing to. So, since the specialized services are also tended towards us, the men.
With your wife, because yes, we men, it is the same. A woman, a man, we are all the same.
Mulago Specialized Women and the Men Hospital, and then that one.
Is for women.
Okay, it is good. When doctor and the team.
Hey, if your wife gets value, this.
There's a bit of complaint that is out there when it comes to fertility.
Let them go to
the concern of fertility is true.
Yeah, we only have 1 day in a year. Women.
The reverse is true. So
relating to the